This is Dr. Anushi, Assistant Professor of Oncology, United The today's topic of my presentation is Hodgkin lymphoma. In today's lecture, we will cover the list of WHO classification of Hodgkin lymphomas with cases, morphology, and clinical features. What is lymphoid neoplasm? Basically, WHO or classify the lymphoid neoplasm on the basis of morphology, immunophenotype, genotype, and clinical measures into five broad categories, which are separated according to the cell morphology. Like 85% to 90% of the cases are of B cell origin. 8 to 10% are T cell origin, and rarely it is originated from natural cells. Lymphoid neoplasm associated with immune abnormalities, both a loss of protective immunity like susceptibility to infection and a breakdown of tolerance like autoimmunity. The incidence of lymphoid neoplasm increased with inherited or acquired immunodeficiency states. When we talk about the classification, WHO classify the lymphoid neoplasm into five broad categories. Number one, precursor B cell neoplasm. It includes B cell acute lymphoblastic leukemia and or lymphoma. When we talk about the peripheral B cell neoplasm, this is the list of neoplasm which covered by the peripheral B cells neoplasm like chronic lymphocytic leukemia, small lymphocytic lymphoma, B cell promyelocytic leukemia, lymphoplasmacytic lymphoma, splenic and nodal marginal zone lymphomas, extranodal marginal zone lymphoma, mantle cell lymphoma, follicular lymphoma, marginal zone lymphoma, hairy cell leukemia, plasmacytoma, plasma cell myeloma, diffuse large B cell lymphoma, and Burkitt lymphoma. The third category is precursor T cell neoplasm, which includes T cell acute lymphoblastic leukemia or lymphoma. And fourth category is peripheral T cell and natural killer cell lymphoplasm, includes the T cell promyelocytic leukemia, large granular lymphocytic leukemia, mycosis fungoides, Stevie syndrome, peripheral T cell lymphoma, unspecified anaplastic large cell lymphoma, immunoglobuloplastic T cell lymphoma, enteropathic associated T cell lymphoma, paniculitis like T cell lymphoma, hepatospleen, gamoid T cell lymphoma, adult T cell leukemia, lymphoma, extranodal natural killer or T cell lymphoma, natural killer cells, leukemia. And the fifth and most important category is Hodgkin lymphoma, the lymphoma of free stem cells and its variants include nodular sclerosis, mixed cellularity, lymphocyte-rich lymphocyte depletion, and lymphocyte B dominance. Hodgkin lymphoma basically a disease which malignant cells form in a lymph system or lymphoid tissue. It is spread widely early in their course in a less predictable fashion. 2/3 of cases present is enlarged, non-tender lymph nodes greater than 2 centimeter. 1/3 present with symptoms related to the involvement of extranodal sites like skin, stomach, or brain. They spread widely early in their course in a less predictable fashion. It is a variant of Hodgkin lymphoma and constitutes only 4% of all the non-Hodgkin lymphomas. The growth of small cell lymphocytic lymphoma cell is largely confined to proliferation centers. And towards the pathogenesis, the deletions of 13q43, 11q73, and trisomy 12 occurs in the small cell lymphocytic lymphoma. And the molecular characterization of the region deleted on chromosome 13 has implicated two microRNAs, microRNA 15A and microRNA 16.1 as possible tumors of research achieved. Towards the morphology of small cell lymphocytic lymphoma, they show diffusely effaced lymph node with small lymphocytes 6 to 12 micrometer in diameter. And also show round, slightly irregular nuclei with condensed chromatin and scant cytoplasm. They also show proliferation centers, which is a pathognomonic or SLL. And the peripheral smear shows smudge cells like fragile disrupted lymphocytes. And in bone marrows, splenic white and red pulp, the hepatic total red shows tumor infiltrates. On IFC, they express pan B cell markers like CD19, CD20, CD23, and TB5, and the low level of expression of surface IgE like IgM, IgM, and globulin D. Clinically, they appear as EC fatigability, weight loss, anorexia, generalized lymphadenopathy with hepatosplenomegaly, leukopenia, disrupted normal immune function, hypogammaglobulinemia, hemolytic anemias, and thrombocytopenia due to autoantibodies by non-plastic T cells. This is another type of non-Hodgkin lymphoma, which is follicular lymphoma. It is most common form of indolent in United States, affecting 15,000 to 20,000 individuals per year. Occurs in middle age, affects males and females equally, and it is a less common type in Europe and rare in Asian populations. Arises from germinal center of B cells. Chromosomal translocations of between 14 and 18 chromosome in BCL2 gene is the hallmark of the follicular lymphoma. Basically, BCL2 antagonizes the apoptosis, and the mutations occur in the MLL2, which encodes a histone methyltransferase that regulates gene expression. Morphologically, they show nodular or diffuse growth pattern. In majority of cases, small cells with irregular or clean nuclear contours and scant cytoplasm is also called as centrocytes like small cleaved cells. They show larger cells with open nuclear chromatin, several nuclei, and modest amount of cytoplasm referred to as cytoplasm. Peripheral smear of follicular lymphoma cases show lymphocytosis like usually less than 20,000 cells per millimeter cube. And bone marrow show paratrabecular lymphoid aggregates and it infiltrates in splenic white pulp and hepatic triads. On IHC, they show normal germinal center B cells expressing CD19, CD20, CD10, and surface immunoglobulin BCL2 and BCL6. Clinically, they appear in painless, generalized lymphadenopathy, rare extranodal involvement, gastrointestinal tract, CNS, and testes. Histological transformation to diffuse large B cell lymphoma in 30 to 50% of cases. This is another type of non-Hodgkin lymphoma, the diffuse large B cell lymphoma. It is most commonly occurring type of non-Hodgkin lymphoma with slight male shift. Occurs in about 16 years of age. Less common occur in young adults and children. In pathogenesis, the dysregulation of BCL6, a DNA binding zinc finger transcriptional repressor required for the formation of normal germinal centers. In which translocations in BCL6 and chromosome 3 to 27 in 30% of cases occur. Acquired mutations in BCL6 promoter required for autoregulation, which is an important negative regulatory mechanism. Mutations in the MIC gene and a mutation related to follicular lymphoma. In morphology, they show large size diffuse pattern of growth round oval nucleus, vesicular multi-lobated or cleaved nuclei, single or multiple centrally placed or adjacent to the nuclear membrane nuclei, moderate to abundant cytoplasm with multinucleated cells with large inclusion resembling B external cells, which is the malignant of Hodgkin lymphoma. On IHC, they express CD19 and CD20, and they also show variable expression of CD10 and BCL6 in germinal center of immune cells. Clinically, they appear as enlarging mass at a nodal or extranodal site like GIT, skin, bone, and brain. They involve ring and oropharyngeal lymphoid tissue like tonsils and adenoids. They also infiltrate spleen and liver, show bone marrow involvement less commonly and rapidly fatal without treatment. Burkitt lymphoma is another type of non-Hodgkin lymphoma, occurs in individuals infected with HIV and TB. Fastest growing human tumor and occurs mainly in children or young adults. What's the pathogenesis? It includes the translocation of the MIC gene at immunoglobulin H locus of 8 to 15 or IG kappa, translocation of 2 or 8, 2 and 8 or lambda, a translocation of between 8 and 22 light chain locus. MIC, a master transcriptional regulator, increases the expression of genes that are required for aerobic lipolysis, which is also called as Warburg effect. The Warburg effect involves in biosynthesis of the building blocks like nucleotides, lipids, proteins for cell division. Morphologically, this shows diffuse infiltrate of intermediate size lymphoid cells 10 to 25 micrometer in diameter, round or oval nuclei, post-chromatin, several nuclei, moderate cytoplasm, high mitotic index, numerous apoptotic cells, phagocytes with abundant cytoplasm, creating a characteristic state appearance, and the bone marrow tumor cells with slightly clumped nuclear chromatin, 2 to 5 distinct nuclei, and royal green cytoplasm containing clear cytoplasmic vacuoles. On IHC, they express surface IgM, CD19, CD20, CD10, and BCL6. A phenotype consistent with a germinal center B cell origin in expression of the anti-apoptotic protein BCL. Clinically, they appear as a mass involving the mandible, involvement of abdominal viscera, kidneys, ovaries, adrenal glands, ileocecal, and peritoneum. Involvement of the bone marrow and peripheral blood is uncommon. The mantle cell lymphoma is another type of non-Hodgkin lymphoma, and it is an uncommon type of lymphoma present at 50 to 60 years of age with male predominance. It occurs due to translocation between chromosome 11 and 14, involving the immunoglobulin S locus of chromosome 14 and the cyclin D1 locus of chromosome 11. Leads to overexpression of cyclin D1. The upregulation of cyclin D1 promotes G1 S phase progression during the cell cycle. On morphology, it shows nodal tumor cells may surround reactive germinal centers to produce a nodular appearance and profile. The diffuse effacement of node, proliferation of homogeneous population of the small lymphocytes with irregular to occasionally cleaved nuclear contours, dense nuclear chromatin, inconspicuous nuclei, and cytoplasm with occasionally intermediate size cells with more open chromatin and brisk mitochondria. On IHC, they express high level of cyclin D1, CD19, CD20, and moderately high levels of surface immunoglobulin like IgM, IgD with kappa and lambda genes. CD5 and CD23 distinguish it from CLL or SLL. Clinically, they appear as the painless generalized lymphadenopathy. Extranodal involvement include the bone marrow, spleen, liver, and gut. Occasionally, mucosal involvement of small bowel colon produces polyp-like lesion also appear. Another variant of non-Hodgkin lymphoma is hairy cell leukemia, and these are the rare B neoplasm, which occurs in middle age with males with a median age of 55. A male to female ratio is 5:1. Physiologically associated with activating point mutations in the serine or threonine kinase BRAF, which downstream the RAS in the MAPK signaling cascade. Towards the morphology, they show leukemic cells have fine hair-like projections, round, oblong, or reinformed nuclei. Moderate pale blue cytoplasm with thread-like or flap sections. The number of circulating cells in is highly variable. The bone marrow diffuse interstitial vibrate with oblong or reinformed nuclei, condensed chromatin, and pale cytoplasm. They also show cells enmeshed in an extracellular matrix composed of reticulin fibrils. They usually cannot be aspirated, like clinically difficult, referred to as dry tap, and are only seen in bone marrow biopsies. Splenic red pulp is usually heavily infiltrated, leading to obliteration of white pulp and a beefy red cross appearance. On IHC, they show CD19 and CD20 positivity, surface immunoglobulin, mostly immunoglobulin G, CD11C, CD25, CD103, and annexin A1. Clinically, they present as infiltration of the bone marrow, liver, and spleen. Hepatomegaly less common. Splenomegaly, lymphadenopathy is rare. Pancytopenia and infections. Thank you.